should introduce Dr. Yasser Huzayen, who will talk about how to minimize readmission for heart failure. And this is very crucial, Dr. Tariq. The main goal of treatment of heart failure is to reduce hospitalization. I think so, yes. And the main cost also of heart failure management is from rehospitalization.
I think if you are waiting for a traditional lecture, you'll be mistaken. So I'd like to have some sort of another scope, as you kindly mentioned, for the readmission and how to minimize. First of all, let me show my agenda. Heart failure and burden of readmission, overview of causes and the challenges, management to minimize readmission, and take-home concepts. As regards heart failure, we all know it's one of the commonest causes of hospitalization, and more than $30 billion in US healthcare expenditure are spent annually. And don't forget that more than half of heart failure hospitalizations are HFpEF patients. And less economic privileged patients cannot afford therapies, and this would lead to more mortality and readmission. We all see these clinical scenarios in our practice. The patient comes out of the hospital and in a wheelchair, he is back again in few days or even hours. Can you imagine? What a burden. Readmission are expensive, and it's not that expensive as regards the patient himself, but individual base, family base, healthcare system, national and even global. You can appreciate here, if you see this slide, the trends in total readmissions and congestive heart failure related readmissions, they are a little bit similar or quite similar. And in the lower graph, you can appreciate that the cost of the readmission is far beyond the cost in the index scenario. 30-day is 7 day and 30 days are the main time frame that we are talking about in readmission rates. Here is the Connecticut hospitals and the Kimball Hospital in USA, and you can appreciate here that heart failure shows the most important cause for readmission. Also, this figure is very important because we not only comparing congestive heart failure with acute myocardial infarction and pneumonia as regard the readmission, but also you can see here that in the pre-reform, those who went into hospital 2004 to 2006, and the other graph, those patients from 2008 to 2009. You can appreciate here that the level is too much as regard the readmission. Also, if this is very recent subject here, it's 2020. When we compare the trends in mortality and the readmission in acute myocardial infarction and in heart failure patients, you can see that the slope clearly, it's very clear that you see the scope or the slope, of the heart failure in the bottom graph is nearly no slope. We are facing much failure. So what about the overview of causes and challenges? Here is the index event. The patient comes again with repeated episodes, and at discharge, early vulnerable period or phase, 7 days or 30 days, and there is also a late vulnerable phase. This was explore today with too many lectures, because hospitalizations is not just a patient with deteriorating NIHA class and he comes into hospital taking diuretic and comes home. It is accompanied by cardiac function failure by time. Disease has a progressive effect. As early as 1995, they tried to figure out the causes of hospital readmission for congestive heart failure, and they stated that over 2/3 of heart failure readmissions are preventable. You can imagine? A lot of causes were put here, and it does not differ too much from now, but the terminologies are a little bit different. Here are the top barriers to reducing readmission rates, and you can see here the patient hands-off, accessory to primary care, all these parameters or barriers you can appreciate a lot, and we face it every day. This was 2012 and 2014. They put the non-adherent patient on top of the list, poor control, hands-off, family support, etc. And we can summarize them in few bullets. Early inappropriate discharge. The patient was not subjected to discharge, and you discharge this patient with inappropriateness. Improper treatment. Okay, we all will obey the guidelines, of course, but sometimes, as one of the professors from, I think, Sweden or talk about the attachment for a good clinician that is an expert in heart failure to give proper treatment. Uncontrollable comorbidities, and I'll show you a slide that is striking in few minutes. Health system failure, cost issues, insurance deprivation, etc. Patient issue, like cognitive issues, and I'll show you a very interesting slide into a couple of slides. Reluctance, ignorance, lifestyle, and communication failure as regard the patient with the hospital or the primary care physician or the consultant. Here is the cognition issue. Cognitive impairment, there was a cohort study of more than 700 patients hospitalized with heart failure who got many COG. They tried to have with these patients just very interesting log to know who are in a cognitive impairment state, and give them score less than 2, high likelihood of cognitive impairment, and score 3 to 5, low likelihood. Imagine you have a patient, 8 years old, and you are prescribing her, female patient, drugs when she's discharged out of the hospital, and tell her to take the medication if she's going to home, or to the caregiver if to a facility. They try to ask them, please draw the clock and plot the clock to see if you can or not. This patient is a little bit pretty good. This, the other patient forgot to put 11 o'clock. Oh, we started the bizarre shapes. Here, there, there, there. Can you imagine you are prescribing drug to a patient with these cognition impairment, and you tell him, okay, good luck, go home? These many log showed us that with the high likelihood of cognitive impairment is linked with the readmission for the hospital, and the vice versa, of course. And this is a very interesting slide, because not all the patients are readmitted for the same cause. We have a lot of comorbidities, and the heterogeneity is there. So around 2/3 are readmitted for other causes. Please put this in mind. Low income equals more readmissions. What and how to manage or to minimize the readmission? Please, this is a very primitive slide, but it's very important because our patient is oscillating between NIHA class 2, 3, 4. He's oscillating here and there. But don't forget that the stage of the heart failure is one-way ticket. Once you go for stage B, you'll never go back for stage A. Stage 3, you'll never go back to stage B. So try to build up your mind setup and try, please, not to have the patient to go from a stage to a higher stage, because this is translated into clinical failure as regard the NIHA class. Please control the umbrella from above. Here are the strategies to help to prevent hospital readmissions, and you can appreciate all what we tried to figure out whole the presentation, the pre-administration coaching, the inpatient coaching, the improved discharge notes, etc. And if we come to the guidelines, please stick to the guideline-mediated therapy. Before hospital discharge, go for guideline-mediated therapy. Know your barriers, your limitations. Optimize therapy. Beware of renal function and electrolytes. Heart failure education, self-care, adherence. Very important to have a multidisciplinary heart failure. You are not the sole player. You are not Messi or Muhammad Salah. You have a multidisciplinary team to catch your patient out of the hospital. A follow-up visit within 7 to 14 days, or even a phone call, sophisticated phone call with the patient would be appropriate. And the European, we showed the American one. The European tell us that the pre-discharge, nearly the same items that have been discussed throughout all the lecture. Two important points, please. Regular aerobic exercise if the patient can. Patients with a stable HF-ref would reduce the risk of hospitalization, and enrolling of multidisciplinary team would reduce the risk of heart failure hospitalization. In a nutshell, this is very important, and I think it's the master theme of the presentation. More strategies equal lower readmissions. When you apply one or two measures, you have high readmission rate. Once you apply more and more strategies, you can go for much more lower readmissions. My take-home concepts as regard hospital readmission for heart failure is unfortunately common. Burden is affecting individuals, families, healthcare system, national and global aspects also are there. The main causes are early and inappropriate discharge, improper treatment, uncontrollable comorbidities, healthcare failure, cost issues, insurance deprivation, etc. Patient issues, don't forget please, the patient, to educate the patient, the health giver, the nurse, to how to manage the drug and lifestyle with the patient. Also, the communication failure is of importance, as I have just mentioned. Addressing all the causes is the clue for minimizing hospital readmission in heart failure. And please, it's not only about the disease, it's all about the patient. Put the patient in your center and in your goal. Thank you.
Thank you, Dr. Yasser, for these very professional illustrations of the problem of heart failure. I think in Egypt, if we look to our country, we don't have the luxury of admission and readmission of heart failure, especially in the situations of the COVID pandemic in this year and maybe in the next 6 months of the 2021. I think your message should be directed to the general physicians, general practitioners, in order to minimize the readmission of patients with heart failure. In the community of the cardiologists, we know the plan and how to manage patients with heart failure. But in our situations, there is a lot of patients either didn't have the chance to be admitted to the hospitals, either due to incapability of these hospitals and reimbursement of the management of those patients. The second, most of them are afraid of having an infection like the COVID-19. So I think our message should be directed to a lot of doctors. They should know the message, how to minimize and how to manage with simple tools, especially in poor areas in our country with this problem. There is a lot of theoretical lectures and a lot of trials, but we have to stress on how to manage those patients with simple tools in our country.
Thank you, Dr. Yasser, for this elegant presentation. I have a small comment. The drugs that Dr. Mohammed mentioned in the last trial is not only for improving survival, but also for reducing the morbidity and risk of rehospitalization. So despite diuretics is very good for symptom relief, however, the main drugs such as RAS blocker, RNA beta blocker, or mineral receptor antagonist should be started in appropriate way inside the hospital, and the patient should be discharged on appropriate doses to avoid the risk of rehospitalization again.
And I think this is the very interesting point. They do it in some of the centers. They put a checklist for the cardiologist at admission and at the patient out of the hospital to fulfill and not to forget any item as regard the medication, the path of the clinical status of the patient, and the discharge form goes for who would give the health care or the health care provider thereafter.
Thank you, Professor Yasser. يمكن أنا يعني from here our gathering heart failure summit, I recommend that in every hospitals, especially the faculty hospitals, we have to have outpatient heart failure clinic. This is
outpatient
heart failure clinic.
Yes.
This is
yes,
very important to achieve adherence with the patient. You mentioned one factor of the repeated admission that the patient lost after discharge. There is no follow-up. My hope that we encourage in our faculties in Alexandria, in Ain Shams, in Asr al-Aini, in every government hospital to encourage heart failure outpatient clinic. This is very important to achieve adherence. If the facilities are available, we can use rehabilitation centers to also, after discharge, the patient go for rehabilitation, and this may decrease the readmission and improve prognosis. I have a small question and your comment about the BNB, the guidelines of heart failure 2017 American recommend the use of N-terminal to measure N-terminal BNB before hospital charge for prognosis. فwhat's your يعني actually احنا ما بنعملش الكلام ده، بس يعني انت رايك هل ده هيبقى له اهميه؟ انت دلوقتي قلت احنا عايزين proper management، يعني one of the factors is improper management. Discharge and then readmit second week or the second month before because of inappropriate management. Can we help us this measuring of before discharge to achieve adequate control and for prognostic implication? What's your comment?
You are absolutely right, Professor Tariq, but it's all about the cost effectiveness and the burden on the health system. I do recommend, as you, 100% to do so, but what about the logistics? We are talking about medicine and the logistics. So the gap is there between both. So I do recommend what you have kindly said, but what about the cost, the availability, how to deliver the message for this? I think we need a lot on the way.
We conclude by a recommendation, heart failure clinic.
Yes.
In our hospitals, it's very important, outpatient clinic.
It's the land of heterogeneity. To send a patient from hospital to home or facility.
Thank you.
Thank you, Dr.
Thank you, Dr. Yasser.
Thank you.
Very much.